Well, good morning. Thank you all for joining us today. I'm Patty Gravitt. I'm the Deputy Director of the NCI Center for Global Health. In 2021, in commemoration of the CGH 10th anniversary, we launched the NCI Global Cancer Research and Control Seminar Series. And in this series, we feature talks by researchers and cancer control experts working in global oncology and provide opportunities for discussion and collaboration around impactful and innovative work that addresses cancer morbidity and mortality worldwide. In today's session, I am so very happy to welcome Drs. Sylvia Adebajo and Dr. Rebecca Nowak from I want to just say that I'm particularly proud to welcome these two because Becca was one of my PhD students many years ago, and it's so wonderful to see how she and her colleagues are advancing the science around such important things globally. So Becca Nowak is an assistant professor and an infectious disease epidemiologist at the Institute for Human Virology at the University of Maryland, Baltimore. She's also an associate member of the Population Science Program at the University of Maryland Marlene and Stewart Greenbaum Comprehensive Cancer Center. Dr. Sylvia Adebajo is a public health physician focused on communicable diseases, primarily HIV epidemiology. Dr. Adebajo is also the country director at the Maryland Global Initiative Corporation in Nigeria, which is an affiliate of UMB and has a dual appointment with the Institute of Human Virology, Nigeria. Drs. Nowak and Adebajo have been working together with IHVN to support the TRUST study, one of the largest cohorts of sexual and gender minorities in sub-Saharan Africa. The TRUST cohort was initiated in 2012 in Lagos and Abuja, Nigeria, and has made seminal contributions to the key population research with 50 publications. Dr. Nowak specifically focuses on HIV, human papillomavirus, or HPV, and the prevention of anal cancer. And Dr. Adebajo focuses on social determinants of HIV service delivery and health systems strengthening among sexual and gender minorities. Drs. Nowak and Adebajo are building off the HIV prevention and care work of TRUST to bring cancer prevention through the IMPACT study, short for Integrated Model for the Prevention of Anal Cancer using Screen and Treat for High-Grade Squamous Intraepithelial Lesions, or HSILs. IMPACT will use implementation science to accelerate the rollout of proven, efficacious cancer prevention strategies to a low and middle income resource setting. Their long-term goals are to bring public health prevention strategies for sexual and gender minorities who are living longer with their HIV because of effective antiretroviral treatment, but need a trusted community venue to access healthcare professionals. In this talk, Drs. Nowak and Adebajo will describe the TRUST cohort and key infrastructure that supported the introduction of cancer prevention into this group. They will provide background on the prevalence and persistence of high-risk HPV for members of the cohort. And finally, they will describe a one-year anal cancer screening and treatment program nested within TRUST and how that led to the development of the IMPACT study. Before turning things over to Drs. Nowak and Adebajo for their presentation today, I'll go over just a few logistics items. Please note that today's presentation is being recorded and will be available on our website at cancer.gov/global health. You can find information about future presentations on our site, and I really encourage you to do that, and by following us on Twitter at NCI Global Health. Questions will be addressed during the designated Q&A time immediately following the presentation, and during that time, you may either use the raise hand feature found under reactions and wait to be called on, or you can also type your question in the chat box. If you are called on, please unmute yourself and ask your question. And so now we're really happy to begin our presentation. Welcome, Drs. Nowak and Adebajo.
Good morning, everyone. Good afternoon. Depends on what part of the world you've logged in from. It's a pleasure to be part of this and to invite Becca and I to make a presentation on the TRUST cohort and anal HPV and cancer control in Nigeria. For the outline, I will speak to the background on the TRUST and to set the context for this presentation. and then hand over to my colleague, Becca, who will take us through human papillomavirus while living with HIV, as well as talk about the pilot study of anal cancer screening and treatment. Setting the context, Nigeria is one of the many countries in sub-Saharan Africa. It's located in the western part of sub-Saharan Africa. Although it has a very small landmass, it's the most populous country on the continent, with over 200 million people. Unfortunately, sexual and gender minorities who are Nigerians are disproportionately impacted with HIV. Within the country, the HIV prevalence ranges from 11% to 44%, compared to 1.4% in the general population or non-SGM population. They are the largest contributors of undiagnosed HIV infections. They have limited access to prevention and treatment services. And at the same time, unfortunately, they are also at heightened risk of discrimination and human rights violations because of their same-sex sexual and social practices. This chart just gives you an idea of the HIV prevalence, comparing the prevalence within the SGM community versus the non-SGM populations. As you can see, over the years between 2007 and 2020, the HIV prevalence among the SGM population towers above the general population prevalence, about 4 to 5 times higher than the general population prevalence, which underscores the need for SGM-focused interventions. Again, because of the pervasive stigma, homophobia, and discrimination within the Nigerian context, in 2024, the Same-Sex Marriage Prohibition Law Act was signed into law in 2024. And that led to criminalization of same-sex marriage. It forbids any cohabitation between sexual partners. It bans public show of sexual relationships and prohibits any form of associations within this community. And this graph here shows the immediate effect shortly after the same-sex marriage prohibition law was signed, act was signed into law. As you can see here, it's heightened stigma and discrimination, from fear of seeking healthcare to avoiding seeking healthcare completely because they were verbally harassed or they were blackmailed, and they couldn't socialize and all that. And you can see the differences between the pre-law and post-law era. It was against this backdrop that the cohort study was established in 2012. And this is a collaboration between US collaborators and Nigerian collaborators. And this has spanned through the period. And over the years, we have published a number of seminal articles published in international journals of repute, including the Science, Lancet, and so on. And this is the largest cohort in sub-Saharan Africa of SGM. It's a healthy partnership between all these collaborators and members of the SGM community. That's the International Center for Advocacy and Right to Health, where both partners, are domiciled in or located in the same premises, and you have a very healthy relationship and partnership over the years, which we have enjoyed. Now, how were these, the members of the cohort recruited? Because of the pervasive stigma and discrimination, the SGM population were largely on the ground and hidden. And so the best method we could adopt to reach this population was this responder-driven sampling method, starting with a group of well-known members of the community known as the seeds. These are the ones in the diamond shape, and they represented members of the community, one or two of them who were living with HIV, others who were not living with HIV, and others who didn't know their HIV status at the time. And it was an incentivized method where each member was given 3 coupons to recruit their friends well known to them. And so went through several waves of doing so. And over the years, between 2013 and 2020, we found that we're able to recruit 2,795 members of the community across Lagos and Abuja, 2 states within Nigeria. And you can see from here, the red dots there represent those living with HIV, the green dots, those who seroconverted during the course of the study, and then the blue dots were those not living with HIV, and the gray, those who were never tested. So it was, a very rich cohort, and it still is actually. And on recruiting them, enrolling them into the study, each one, and there were 2 sites within, the study, were given a choice of choosing whether they wanted to remain in the one-stop shop, which the one-stop shop would be the trust center or site, which is run by trained SGM-friendly healthcare providers. And then the other part was, within the public health facility. But over time, the members of the community showed preference for, the trust, the one-stop shop. And they were meant to go through 13 visits every 3 months. And at each visit, those who are living with HIV had to go through viral load and CD4 testing, whilst those who were HIV negative were tested regularly, and then they were also commenced on pre-exposure prophylaxis. Now, over the period, there were 441 members of the SGM community who remained HIV negative. Out of this population, 441, 81 of them seroconverted, translating to an overall incidence of 15 per 100 person years, with the incidence being highest among those aged 16 to 19 years compared to the other age groups. But despite the stigma and the seroconversion and everything that goes with living in Nigeria as a member of this community, the retention rate was appreciably high. And over this period, only 5.6% were lost to follow-up. And so at this point, I would like to hand over to my colleague who would take us through the next few slides. Thank you very much. Becca, over to you.
Okay, great. Thanks, Sylvia. So I'm going to talk about human papillomavirus while living with HIV within the cohort. Where did it go? Okay, so I just want to go over a little bit of background on human papillomavirus. So to get everybody on the same page. So human papillomavirus, which I'll refer to as HPV, enters through mucosal breaks here in the squamous epithelium, and it'll infect the basement membrane, okay, the basal cells, and it'll have a relatively low copy number down here. And just note that the immune system, immune cells will be below this layer. So HPV keeps a low copy number, and as the squamous epithelium differentiates and becomes keratinocytes and naturally migrates up, HPV will then amplify. And once these cells die off, then the virus is naturally released. And so what's unique about this habitat for HPV is it's confined to the squamous epithelium, not necessarily well exposed to the immune system, And when it releases its virus particles, there's no stimulation of inflammation. Okay, and so that's important for understanding the pathogenesis. Let's see. Okay, so HPV is kind of unique. You can have the squamous epithelium where you'll have an infection with high-risk HPV. And this is why I wanted to kind of highlight, it's kind of confined in the squamous epithelium with difficult recognition from the immune system, because it can take up to 2 years or so to clear it from detection. So meaning it can be no longer detected from the squamous epithelium. A small proportion of those high-risk HPV infections may continue to persist or remain in the squamous epithelium and continue to be detected. So persistence here, I mean persistently detected. And if you're persistently detected over a long time, you can potentially develop into a high-grade squamous intraepithelial lesion, or also known as high-grade precancer. There's also low-grade too, but I'm highlighting high-grade. Interestingly, if you do have a robust immune system, this can regress, okay? But a small proportion of these will then progress to anal cancer. So you understand kind of the different stages for progression from an infection to cancer. HPV is not just one type, okay? There's multiple type-specific infections, and we designate those as high oncogenic risk or low oncogenic risk. So that you have an idea now, that you have to have that initial infection. And then you have to see kind of what is the burden of that initial HPV infection in the squamous epithelium for men, if you're looking at anal HPV. And what this is showing, this is a pooled analysis from the International Agency for Research on Cancer. This was just recently come out. We actually were able to contribute our data into this analysis. This is from 30,000 men across 64 studies. So it's a very rich data set. And what it's showing is that the initial infection, so if you take a cross-sectional swab, regardless of age, generally men who have sex with men living with HIV have about a 74% prevalence of high-risk HPV infection, okay? And those who are not living with HIV have about a 40% prevalence of high-risk HPV infection. So there's a high burden of high-risk HPV infection no matter where you're taking that sample in time, relative to men who have sex with women who are not living with HIV. This would be more indicative of the general population. Okay. But just having that initial infection, what is really important is to understand if that infection is going to stay there, how you acquire that infection, and how long it's going to persist. And so, and you want to look at that and understand in which risk group is this, where this happens across risk groups. Okay, so this is again building off another IARC study, the International Agency for Research in Cancer. It just came out. And we contributed data to this as well. So this is another pooled analysis, I think 16,000 individuals across 34 studies. So it combines all the data, and what you see is the most oncogenic one that we're most concerned about is HPV 16, and we can see the cumulative incidence of HPV 16, the clearance of a prevalent infection. So an infection that you swab and you see it and you don't know if it's incident or if it's prevalent, we just call it prevalent infection. But if you happen to see a person acquire an HPV 16 infection, we call those an incident infection, and they have different dynamics in terms of their clearance. And so regardless of risk group, right, we have men who have sex with men living with HIV, you have women living with and without HIV, and you have heterosexual men who have sex with women living with and without HIV. And men who have sex with men living with HIV have the highest cumulative incidence, the slowest clearance of a prevalent HPV 16 infection, and slower clearance of an incident HPV 16 infection. But I mentioned to you that there are multiple types of high-risk HPV infection, and I did highlight 16 in the last slide. But when you have all of those infections during the course of the natural history of HPV, what you really want to know is what is the highest burden, which one is the most carcinogenic. And regardless if you're living with HIV or not living with HIV, HPV 16 here is the most prevalent, okay, among the cancers. This is the most carcinogenic. So this is the one we're most concerned about, okay? And so given kind of what you see for the patterns of the burden of HPV for men who have sex with men and living with HIV, the persistence, the clearance, it's no surprise that men who have sex with men have an 80-fold increased risk for anal cancer as compared to the general population. And you also see a high burden for MSM living with HIV who are younger, okay? Anal cancer is usually happens later and older, but we do need to pay attention that it's for those even 30 to 44 years of age. Okay. So when I started my work, this is going back 10 years. So I didn't have that nice IARC analysis at the time. There wasn't any really understanding in trust or in Africa what the burden of high-risk HPV infection was. So I had conducted a pilot study just to kind of see what was that initial prevalence. What do we have in Nigeria for those living with HIV and not living with HIV? So this is within the trust cohort, a pilot study. And we found that we had a little bit higher for those who were living HIV, higher prevalence of high-risk HPV infection, compared to a meta-analysis that was the most recent data that we had at the time. This is about 31 studies. They were estimating a little bit under 70% high-risk HPV. And then for those who were negative, they were estimating in the meta-analysis about 40%. We found 40% high-risk HPV in those who were not living with HIV. And those are the same numbers I showed you in the initial slides, right? So everything's consistent. And so you have the HPV types, and you kind of want to know in Nigeria for our cohort, what types are really coming out as the most abundant types. Okay, so we've genotyped them out. We stratified them by HIV status. These are all the high-risk HPV types, and they're in rank order in terms of abundance among those living with HIV. And what you notice is that 16 is right here, but we also have a high prevalence of 45, 18, 51, 58, and 35. I want you to note the high prevalence of the low risk types 6 and 11 because they're associated with warts. And we're starting to see, we'll show you stuff about warts later. And if the men had been vaccinated, these are the types in boxes that we maybe could have prevented infection with. Okay, so these are the ones covered in the 9-valent. So we have kind of an idea of what we have cross-sectionally for prevalence. But as I told you through the natural history, we really need to understand persistence. And so we have data, and this is preliminary, but we have data in the cohort where we're looking up to about 15 months of follow-up time. And I have data for up to 4 visits per person. This is somebody living with HIV. This is somebody not living with HIV. All I wanted to do was show kind of the distribution of the types that we can see. And so when you're trying to assess persistence, you're trying to look at these individual type-specific infections within multiple infections. And you'll see here, look, 35 is here, pops out, comes back in, okay? And so you have to define persistence across all the visits. But just to kind of give you a summary, as you would expect, 16 actually comes out as one of our top persistent infections out to 15 months, but it also is similarly persistent as 51. Okay, so it's not just 16, we've got other types that are highly persistent, 45, 18, 35. Okay, and so we're seeing this. Okay. So when I did the baseline prevalence and I saw the distribution of high-risk HPV infections, I I had an opportunity to submit on a pilot study to get supplemental funding, and these men are not eligible for a vaccine. And if you work in international settings, then you know that things can take time. And so all I could think of is, with the burden of the high-risk HPV infections, somehow we need to make the initial steps to figure out how can we get screening and treatment into the cohort. Okay. So I took a leap and said I was going to initiate a pilot study on anal cancer screening and treatment. And I had no idea what I was getting myself into, but this ended up being a fabulous collaboration with Dr. Plevsky, Dr. Goldstone, key leaders in anal cancer screening and treatment. So we had a lot of support from UCSF. And the objective of this was just, can we nest this? We had such a unique HIV cancer prevention clinic with active engagement. Could we nest the anal cancer screening and treatment in there? Would they be receptive to it? Could the clinic actually do this? And could we just see if, in fact, you introduce this, could we establish the baby steps we need to then maybe keep building on this? Because, as I said, working internationally, these things kind of take time. Okay, so I initiated this in 2016 and got heavily involved with anal cancer screening and treatment. This is Dr. Wuse. So we trained Dr. Wuse, a pathologist and a surgeon. We brought them to the States, and we initiated screening and treatment within trust. And so I told you we're working with UCSF, with Dr. Plevsky, we're working with Dr. Goldstone, and their International Anal Neoplasia Society had general guidelines of how do you start training somebody. And so we used those to help guide our training locally with Dr. Wuse and the team. And so the guidelines suggest that you screen about 100 persons, and then Dr. Plevsky would come into country. So what we decided was we were going to do the 100 screenings, and this was our training phase. And then we were going to initiate a pilot study to then see how well we could detect high-grade disease and what were the factors associated with high-grade disease. And we did this all in a year. So this is just showing you the number of screenings we did per month. Okay, for the first 5 or so months, and then the 300 and plus screenings that we did for the full year. Okay, so there was we surpassed the number that was expected to screen in a year. Okay, Dr. Plevsky said maybe you'll get to 100. Okay, so we did over 525 screenings. There are some people who did come back. They wanted the repeat screening. So there are some duplications, but overall we enrolled 444 persons who engaged in the screening and treatment study. And just to show, before I show you the dysplasia data, you want to make sure that there's no difference if you see differences between the two phases, whether there's differences in the population that you initially recruited into the training phase versus the pilot phase. And so I want you to see that age distribution didn't change. The number of years since sexual debut, we still have about 50% of the people screened either way had more than 8 years since initial sexual debut, anal sexual debut. Lifetime number of partners was very similar. The one thing that was different was that we had a lot more people who were living with HIV during the training phase. So you would think that that might impact detection of high grade. And smoking is only about 22%, and was similar between the two groups. And so when we did the screening, in the training phase, our physician didn't biopsy as much, and 90% of the people screened were considered normal, and we only detected about 10% low-grade squamous intraepithelial lesions. So these are the low-grade lesions, okay? And with time, as we start to enter into the pilot phase, you have to note that she's getting more and more practice and taking more and more biopsies. We do see a higher detection of low-grade lesions, but we only saw about 6% detection of high-grade. Given the high prevalence of HIV, we thought this might be an underestimate of high-grade disease. And so one thing we did after we had collected all the data was we wanted to kind of look and see what had been her learning curve for detection of dysplasia. So what would have been nice is to do this learning curve if we had been able to detect more high-grade disease, because that's what you really want to look at, the learning curve, because that's the one you're trying to find. But we didn't have enough, so we had to use any dysplasia. So this includes low-grade and high-grade. And so this is just showing you the prevalence of any dysplasia over the cumulative number of people screened, right? And so it does follow a nice S-shaped curve. And it turns out we get up to about 200 screenings before she's starting to see kind of a similar prevalence of anal dysplasia. And I just learned, you know, doing this study, this I thought would have been a really helpful technique if we had been doing this along the way. Because there are some barriers with the learning curve, and we learn this afterwards. Okay. And just to look at kind of some of the how the factors associated with both low-grade disease or high-grade disease, the factors that were strongly associated with low-grade was been living with HIV, and interesting concurrency with only men. So concurrency meaning having two or more partners of men, male partners at the same time, and warts. Okay, I mentioned that we have a high prevalence of 6 and 11, so it's no surprise about the warts here. And factors associated with high grade, it was very interesting to see that having more time since you've been initially exposed through anal intercourse, that was associated with high-grade disease, and then warts strongly associated. So the warts are important because not only do they show possibly there might be an earlier marker of what you've been exposed to, because warts might progress a little faster than developing high-grade disease. We had a relatively young population, but also warts may also be an indication of how you respond immunologically to HPV. So it can kind of work as an indicator for two things. And while we were conducting the study, I was concerned that what if they undergo the procedure and they don't like it, and it could just stop everything. Okay, so I kind of wanted to gauge how did they feel about it. I was very concerned. I wanted to make sure that if we could ever bring prevention in, that this would be something that would be received. Okay, so we initiated the satisfaction survey once we started the training, once we started the pilot phase, and it was a 22 point questionnaire, and we modeled it off of a prior study that was done in Colorado, and they had used they had kind of modified a colon cancer screening satisfaction survey. And so what you see here was a 5-point Likert scale that you could answer the questions on, strongly disagree to strongly agree. And I'm just showing you the prevalences of the responses for each of the questions. So I was very anxious about having the procedure. You know, 90%, 91% here are saying they agree, they're very anxious. But I was surprised to see that they all agreed, strongly agreed, from some of them, that they thought it would benefit their health, and that they would recommend it to their friends. So this also was reassuring if we were to bring bring cancer screening back. I snuck into the questionnaire a few questions, very clinically related, that are signs that you may have anal cancer. So I said, well, if you have rectal or abdominal pain, if you have bleeding, constipation or strain or strange shaped stools, would this initiate you? Would you kind of want to go and get screening? And many of them said they neither agreed nor disagreed. So I don't think they knew what to answer. And a very small proportion agreed. So it was kind of another indication that maybe our ability to convey what are the symptoms for anal cancer wasn't done well enough, or we needed to change how it was conveyed, because it didn't seem to register that, oh, if I see this, I need to go and get screening. Okay. And just lastly, within this particular pilot study, Dr. Plevsky said, well, it's possible that maybe you don't have the high grade HPVs, right? It could be that my earlier work, when we did the initial pilot study, we saw a lot of high risk HPV. Maybe the people that we screened didn't have high risk HPV, so they wouldn't. That's why we saw a lower detection of high grade disease. So we had swab samples from everybody who had been screened, and we tested them for HPV. And we do have a very high prevalence of any HPV, high-risk HPVs, as well as the warts. Okay, it's particularly for those living with HIV as compared to those who are not. So it was not a matter of not having the infections. We really had some challenges with detecting high-grade disease, even though we screened 500 people. We did 500 screenings. And so I've been kind of all this work happened back in 2017, 2016, and then I was trying to get all of our work summarized. And I was thinking of late, well, we did this a while ago, maybe anal cancer isn't a concern. So I kind of wanted to get a gauge from the sexual gender, from the SGM community within trust. Is anal cancer a concern right now? Because I kind of need to know if this is something that's important to you, because in anticipation, I don't want to presume that it's something you want or need. I don't want to just introduce anal cancer screening again, if I could, if it's not something you're interested in. And so we conducted a survey in November of 2021, and in under 4 weeks, 800 men had responded to the survey to assess their level of worry about anal cancer. We had it on a Likert scale, like what their level of worry was for anal cancer, 5-point from no worry to 100% very worried or extremely worried. And we combined those down to less than 25%, 50%, and 75 to 100% is 3 categories. So on this ordinal scale, and then we evaluated factors that were associated with that increasing levels of worry. And we also asked, if we were to bring back future anal cancer screening, do you want us to contact you? And almost everybody that had answered the original survey said, yes, please, here's our contact information. We signed the consent form. Okay. And so we have evaluated some of those factors of what was associated with an increased level of worry for anal cancer. What's a little concerning for me is that those who are older were not as concerned as those who are younger. This age of 35 is the age we really need to start looking for high grade in cancer. So we'll have to do some work here. Those who had been previously engaged or received their HIV care and trust had higher level worry. They might have learned about the study, been exposed to our earlier anal cancer screening work. Those who prefer the bottom sexual position or engage in either bottom or top had a higher level of worry. And those who knew somebody who had anal cancer, this surprised me, the number of people that reported knowing somebody with anal cancer, and those who did not know had a higher level of worry. And And then in the fall, when we were doing the worry survey, I've been very cautious about bringing in anal cancer screening and treatment because it wasn't known to be efficacious. Okay, so Dr. Palevsky had been running the ANCHOR study, right? This is a anal cancer HCILS outcomes research study. This was a randomized clinical trial. It was the first study to then look and evaluate whether treating high-grade lesions or active monitoring would be better. Okay, and I've been kind of waiting to see if these results would come out, because there's no sense in bringing it back. I don't want to add any, I don't want to introduce anything if it's not efficacious. So this trial was stopped in October of 2021, and it was stopped early because ANCHOR was finding a 57% lower risk of progression when treating as compared to active monitoring. And this was the evidence that we needed. And so with that evidence, and I've already kind of mentioned, we didn't do a good job of screening. We already know some of the barriers that we had. And I got very excited that we can actually maybe bring this back and then incorporate implementation science to actually do it well and formalize it. And so this led to the development of our impact grant and identify the barriers. We're going to formally evaluate what the barriers are. We know some of them. We inherently saw them when we were there. There was little communication sometimes. There's time zone challenges. There's, mentoring challenges. And so we're going to formalize this. We're going to bring back anal cancer screening and treatment, and we're going to train the standard way and identify those barriers and facilitators and use the CFR framework, right? Is it the process? Is it the implementation? Is it the individuals? Is it the setting, right? The setting, is it the internal, the external? And identify those barriers. Then we're going to map those to strategies, and then we're going to systematically evaluate those strategies and pick the most sustainable, the ones that make the most sense within Nigeria, and develop kind of an enhanced training. So we are really hoping that this is something that could then be set the standard, taking this from a high, this screening and treatment and the training process on screening and treatment to screening and treatment down to adopt it to a low to middle income setting. And so then we'll test it and the standard training and our enhanced training. And that's the summary of our impact grant. Sorry, I'm done. So, oh yeah. So, and then all this took a ton of work, a lot of infrastructure. And so there are many people to thank, both on the US side, our cancer center, UCSF, in Nigeria, my great collaborations with the physicians. This is our surgeon and pathologist team in National Hospital in Nigeria, other supporters of understanding anal cancer screening and treatment, all of our support, financial grant support. And with that, there are any questions, so I'm done.
Wonderful. Well, thank you both to Drs. Nowak and Adebajo for such a fantastic presentation. And wow, I mean, this is such a model for interdisciplinary science, and it's such a model for rapid translation of an evidence base and working together with the people developing that evidence base so that they can translate it right into the implementation almost simultaneous with the evidence coming out. And I think that's just really really motivational. I think it really should motivate all of us to keep doing this. So at this point, we'll open it for questions. Again, if you're able and comfortable, we'll invite you to turn on your cameras so that we may see you for the Q&A portion of the seminar. And as a reminder, if you've got a question or comment, either use the raise hand feature found under the quote reactions button in the Zoom, or wait to be called on or type your question into the chat box. We'll get to as many questions as we can in the remaining time, but we've got a good 15 minutes, so I hope we can have a lively and productive discussion on this really exciting research. Okay, I'm looking for hands, so 1 second. I think, let's see, I'm trying to get my screen so that I can see hands easily. Just give me 1 quick second as the moderator. Okay, I think Geraldina, please go ahead.
Hi, great work. I'm really excited about these results. I had 2 questions. One is you talked about, the screening, but, the other part is the treatment. And you didn't really describe what is available in Nigeria, because that's going to be quite important. And the other question I have is, in your new grant, which is congratulations again, are you just seeing the HRA approach, or are you testing other ways to maybe test like HPV, then triage to HRA? And because, I mean, instituting anal screening using only HRA is, it's going to be really difficult.
So Sylvia, you want me to answer that one? Yeah, so we did have about 23 cases of high grade, and we were not able to treat all of them at the time. So we had brought in all the equipment that we needed, and we had trained the physician on treating the high grade, because once we found it, we offered treatment in the initial study. And so we will, we had, so that was part of why one of the challenges was even getting them in for treatment. And which is why we want the implementation science piece. And then it is challenging to initiate on a very sensitive and expensive procedure for doing the screening and treatment. We are just, I think what we're hoping is that we could maybe then incorporate in some of these algorithms as they're trying to develop, because most of the men are going to be 74% are going to have high risk HPV. And really you kind of want an indication if they're going to have HPV 16 persistence and then screen them. And I think we're just not there yet. And so I'm trying to kind of do things at the same time. So if we can kind of build the infrastructure to know how to do screening and treatment, and then maybe then we can start developing the algorithms and then limit the number of people that then would then go through screening and kind of do it simultaneously. But it takes so long to kind of build that infrastructure. I don't want to wait for the right algorithm first to then later introduce HRA.
So what kind of treatment are these men
Oh,
that were treated?
Hyfurcation. So we're going to use hyfurcation in the clinic. And we have our surgeon, so we're pairing up with our surgeon in case we have more complicated cases.
Okay, wonderful. I think we've got a question from Omar next, please.
Hi, great talk, and always great to hear about all the wonderful work that's being done with the Trust Cohort. So my question is more actually about the HPV vaccine. Do you feel like a lot of your cohorts had no exposure to HPV vaccine? I think that's a challenge we also face here in the United States. And I know that so some of your populations under 25 or 26, and so maybe could still fit, even if they have HPV related disease, to still get the Gardasil 9. So are you able to even get it easily in Nigeria, or is it something to incorporate maybe into the study or into future studies?
Yeah, I would definitely like it if we knew that certain people were negative and we could then get them the vaccine. That would be great. I had reached out earlier on to Merck to see if I could get a little supplemental funding, and it hadn't worked out yet. So, but it's something to think about.
Yeah, but overall the uptake is very low.
There's no vaccination.
No.
Yes, Sylvia, maybe you can comment as well on the vaccination
Yeah.
kind of situation in Nigeria.
Well, at the moment, the vaccine is just available for girls, not for boys, and it's not actually incorporated into the national vaccine immunization program. So if you want to access the vaccine, you have to pay for it, and it's expensive, but it's targeted at the girls, not boys. Again, partly because the evidence hasn't really come out, and then maybe part of it too is the stigma and discrimination, that it hasn't got to the consciousness of policymakers that SGM do exist in Nigeria. So that's something that will gradually catch up. But at the moment, that's the constraints we have.
Great, thank you.
Thank you, Sylvia. I think those are constraints that a lot of people are facing. So I think the global health community empathizes with that with regard to HPV vaccination. I may kind of follow up, not seeing any hands or chats up right now, by just asking, because does the evidence suggest that if you were to vaccinate a sexually active HIV infected man, that you would actually be able to would the vaccine be efficacious, because it is a prophylactic vaccine and not a therapeutic vaccine? Is there evidence in that, as far as you know?
No evidence. Unfortunately, it won't help with clearance. It's not going to help. We need the therapeutic. I keep watching the therapeutics.
Yeah, the therapeutic vaccines. And I do think that it just becomes more and more important to get people vaccinated before they get sexual debut. I mean, I think that's a kind of universal, kind of goal for us. And I'm going to stop talking now and hand it over to my colleague, Sudha, please.
Oh, thank you. And thank you, Drs. Adebajo and Nowak, for the presentation. I was just curious, in one of your slides, you had, the worry survey, and where there was less worry. I just wondered if maybe you can comment on the engagement strategies that are in place to recruit the men, given the political climate that you, Dr. Adebajo, described. So how are you overcoming even just bringing men into the clinic? And if there is less worry, but high evidence of prevalence of high risk in your study, how do you intend to manage that and address that engagement in the impact trial, for instance?
Sylvia.
Becca, do you want to go first?
You go first.
Okay. Well, to start with, we've found over the years that, aside from the responder-driven sampling method, which is, a technique of reaching hard-to-reach populations, over the years, I must say that the political will is improving gradually based on, the results, evidence from, the work that's been done. So we've come a long way. The government now is aware, and they've embraced, the population, and they're providing some form of intervention. Despite that, the population would prefer to access care in safe spaces. So they won't just go into any, not have the high index of suspicion to ask the right questions. So they prefer to go to, they feel safer to go to safe spaces, the one-stop shop. And there are quite a number of them now across the country, where you have trained healthcare providers who would recognize and ask the right questions. I think that's most important. It's asking the right questions, which would make members of the community open up to talk and then to access care. Otherwise, they won't go, and the worries will remain there. I guess the part of the success of this pilot here is that they're getting worried because they know that they have access to treatment for genital warts, for example. They have access to information and all that. And that is what is also increasing the worriness. Without all this, they wouldn't have even known, and so we've come a long way. Becca, do you want to add to that?
No, I think she did it great.
Yeah, that's fantastic. And I think sometimes, you know, kind of the visible warts, you know, can be something that kind of brings people in for the higher risk things because nobody, you know, kind of wants to have to deal with that. Yes, please, Satish.
So thank you both for a great talk. I'm on the NCI campus today, so the audio may be glitchy. So if we have trouble, I'll just put the question in the chat. I guess I have two questions. One is, has there been any kind of political backsliding over the last couple of years in trying to, because that is occurring in, you know, in many places, including in the United States, and I think speaks to the importance of having these safe spaces. But I'm wondering if you've seen, you know, following sounds like some really important progress initially, any backsliding? That's one question. Second question is, I think this is such a nice illustration of trying to do really important public health research in a very hard to reach population, while the environment is changing so rapidly around you, both the research environment, what's available, the political climate. I'm curious what you all were thinking in terms of next steps before Anchor read out as positive, right? Because that wasn't a foregone conclusion, and presumably there were still really important outcomes from the pilot phase that you would have been advancing even without Anchor reading out positively at the time that it did. So I'd just love your thoughts about that. Thanks.
Yeah, and I might take the liberty of moderator to pose the first question about the political, you know, backsliding to Sylvia, and then the kind of plans, you know, kind of from the study, you know, prior to knowing the Anchor results to Becca, if that's okay. Dr. Adebayo.
Yes, thank you very much, Satish, for the questions. Well, to start with, the same-sex marriage prohibition law is still in place. And though we have members of the community who are becoming, you know, more courageous and brave, you know, to fight this, it still hasn't gone, and it's still very much there. So everybody's aware of that, not just the members of the community, but also healthcare providers. So everybody is being careful. So long as it's not out in the faces of people, people will get by. You know, I guess part of it too is that members of the community are aware of, you know, the hostility out there. So they're careful, and they carefully navigate their way around. But then for those who, you know, try it and, you know, just try and adventurous, we still hear of cases where, you know, people are ostracized, they're lynched, they're hostile, they're arrested. So we still hear pockets of those. So people generally are careful, not just members of the community, but also the healthcare providers. I guess it will improve with time, but we're still very much in the trenches. Becca, over to you.
Okay. In terms of like public health impact, I think the two things where I was going was to still be sure that we weren't just staying in the molecular, and we were really going to get into Nigeria and do something for prevention. So I was actually kind of gearing towards seeing what we could do with the immediate concern about the warts. And I knew that if we kind of addressed the warts, it actually might help with prevention eventually, potentially with high grade, just through my interactions with people in the EANS and the International Anal Neoplasia Society. I know people who treat the warts, and then they seem to see a lower reduction of high grade because they just happen to be treating warts. So I think that's where my avenue was going to go, was just kind of focus on the warts, give them some immediate benefit because they are so concerned. I have very young people coming in with very extensive warts, and if we could just have started increasing some treatment early on and using that. So that's what I wanted to do. The other thing I wanted to do was kind of build knowledge base. You know, we're starting to see these one-stop shops, and we have trust as a model. And I wanted to then start introducing the idea of how do we inform them about what the HPV is, what are the symptoms, and kind of do it on a behavioral and informative way to make them informed, so that then they can go and advocate health clinicians and to build that resource. I was trying to then find it within Nigeria. There are a lot of people that want to get engaged with
Yes.
this work.
Great, Dr. Nowak. Thank you so much. And we're at the top of the hour, so I'm going to just conclude our session for today in our series. I want to give, again, a very special thanks again to Drs. Nowak and Adebajo, and to all of you for joining us. Please don't forget that to join us for our May session on tobacco control research in the Middle East and North Africa region. And in June to hear about development of systemic therapies and head and neck cancer in the Indian context. Once again, really quickly, please do visit our website at cancer.gov/global health to find additional information about upcoming sessions, past recorded sessions, as well as funding opportunities in global health research, events, news, and more. And follow us on Twitter at NCI Global Health. Again, thank you so much, and I hope everyone has a great rest of the week and weekend.
Thank you. Thanks, everyone.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.